Hello, everyone. I hope your day is going well. My colleagues Eva, Joseph, Sushma Charya, and I welcome you to part 3 of the research methodology series. I have a few quick reminders before I invite our speakers. We appreciate you joining us and introducing yourself in the chat box. Please be sure to write your questions in the Q&A tab and complete the evaluation. Your feedback is important to us, and we will send you the webinar recording link in a few days. Next slide, please. That's good. In part 2, we learned about different types of bias and discussed recall bias and information bias. Today, we will learn about the confounding factors, what they are, and how they can hide an actual association, making it difficult to establish a clear causal link between treatment and outcome. We will also learn the importance of collecting information on the confounding factors and strategies to adjust for confounding effects. Next slide, please. And now I'm pleased to present Professors Lackland, Weber, and Welton to you for another thought-provoking webinar. Over to you.
Thank you so much. It's again our great pleasure to be a part, and I invite you to come. That we selected these topics based on things that you find to be interesting and making recommendations. And so one of those was indeed confounding. And what we'll talk about today is just that. Dr. Weber, Dr. Welton, and I will talk about these different aspects and some of the important pieces. We'll go through this confounding as a whole study and a whole area, but we'll go through it to try to help you get a kind of a quick assessment as you read studies, as you prepare your studies for publication, and how you address the issue of confounding. And again, our disclaimer that is standard all the way through. These are kind of our views, if you will. Today, we'll talk about confounding and its effect on study results. We'll also cover the strategies that you can see and kind of expect as to what you would want to see in a study to reduce the effects of confounding, and being able to detect when you've read a study or you've seen a study or you're designing a study, and how you want to adjust and be appropriate for the confounding aspects. Looking at kind of the standard definition of what we would see with something like confounding. Confounding is a situation in which you have two processes that are not separated. They're kind of related to one another. And we're going to do a number of examples that are hopefully will be there. The confounder, though, I think a very important piece is that the confounding factors, confoundings are study specific. So you have your critical question, what you're trying to do or what someone's trying to do in a particular study. Sometimes a parameter might be a confounder. Sometimes it won't. Very important, that third bullet, so very important, that no variables are always confounders. Even though they're often confounders, something like age, it doesn't mean that it's always a confounder. And we'll do some examples. Let's look at kind of the definition of what a confounder is. If a factor in a particular study is going to be a confounder, it needs to meet three very important conditions. The first is that the factor must be associated with the exposure that's being studied, that's being investigated. The second is it must be independently associated with the outcome being investigated. It's not a step moving from one condition to the other. It's totally independent, but it is a separate association. And very similar, it must not be in the causal pathway between the exposure and the outcome. So as you look at it and you look at a particular situation, so you can see how this would change from, because if you're looking at an outcome, the outcomes are different for different studies, and the factors are different. So each study, you should be thinking in your head very quickly, is this a confounder? If this is this parameter a confounder? And as you read a scientific paper, you have to think, is this a confounder? Are these results really affected by the confounder? And as you develop your studies for publication, you also want to consider and addressing the areas of confounding. If we think about what we do for that's the big piece. So I have a confounder. What do I do? Confounding obscures the real effect, and it needs to be prevented or removed as much as possible. And you do this typically in the design, but you can also do this in the analyses of your results. It can be addressed again during the study design by the use of something like randomization, if you're doing that, restriction, or actual matching, if you're doing that type of study. It can also be controlled by adjusting after the completion of the study by either stratifying by the confounder areas and the confounding pieces, or you can actually be doing an analytical type of an adjustment as well into the pieces with this regression analyses or whatever you're using with regards to your analysis plan. It's also important to think about the word effect modification, the effect modifier. And I know many of you have done this, and this is kind of that other piece of it. This indicates that the effect of one variable on another. So a factor that you would see, we've been talking about factors that are confounders. There's also the effect modifier, and there are different measures of effect that this can be where you have a parameter, you have a condition, you have an exposure that is actually functioning as an effect modifier for the outcome, something that you kind of want to study, that you're wanting to do maybe some of the investigation of that condition. A little bit different. You know, the effect modifier is when the measure of the association, like a risk ratio, what you've been looking for, changes over values over time. This is what you're actually studying. This is what's of scientific interest to you. It answers a research question. This is what you're kind of looking for. Is this factor associated with this outcome? That's what you're looking for and trying to study. Confounding, on the other hand, is going to be that distortion of the factors. And so you're looking to say, does this factor affect this? And then you might have something that's distorting that association, either showing that it is a strong association or suggesting that it perhaps is not. So here is just a simple question that we think about vitamin D supplementation. And we're thinking about this as a confounder, but it could also be an effect modifier. So here is, does vitamin D improve frailty? Fairly simple, easy type of an approach, a reasonable type of question. Do you want to be suggesting vitamin D supplement for people that or have low vitamin D, or just want to have it as a simple supplement that might be able to help with regards to frailty? Well, if we look at something like that, both this could be both a confounder. Vitamin D could be a confounder. It could also be an effect modification, depending on what that question that you're trying to resolve. So, for example, as a confounder, vitamin D might be more of a confounder if the different treatment groups differ by a relevant characteristic. For example, you might say that men, women, whatever, maybe respond differently with regards to vitamin D supplementation. Something like that, where vitamin D might be now a more of a bias and more of a different type of indicator. As an effect modifier, though, there might be subgroup effects, and you might want to do that analysis. That might be something that you really wanted to study. That how does vitamin D work in women? How does vitamin D work in men, in young people, in old people? And it's an effect modifier. You're trying to determine how does vitamin D work, as opposed to studying the population and seeing that it works, it works differently, and it has maybe it just kind of affects the other pieces that the vitamin D is affecting. Maybe, and we can talk more about it. So it can be both a confounder and an effect modifier. Another way to look where it's a confounder is that individuals taking vitamin D might appear to be less frail because they have more resources to protect their health, not because of the vitamin D, but simply they can afford, and they have the interest in doing vitamin D. That might be a different person than somebody that doesn't take vitamin D voluntarily. You know, you can ask yourself the question, do people that you know do they take vitamins? People that take vitamins are often different than those people that don't take it, different attitudes. They may be more health conscious. In that case, vitamin D is going to be a confounder, people that take it. However, it might be that indeed vitamin D is more effective in preventing frailty, and because maybe a system better metabolizes vitamin D, or something like this, and does kind of slow down on frailty. So I have a situation again where vitamin D could be a confounder. It could also be an effect modifier. How do
Professor
I address?
Lackland, could
Please,
I?
please.
This is a very, very important issue you're talking about here, because it often comes up unexpectedly in clinical trials or clinical studies. And this is a great example. I've been involved in studies where we've been comparing two treatments, maybe two treatments for reducing blood pressure. And it turns out one treatment is more expensive than the other. And so we did a comparison, and we figured out eventually that it wasn't just that one drug was better than the other. It was that one drug was more affordable than the other. And we hadn't anticipated that difference, but it did affect who actually took the drug during the trial. If you anticipate that problem, then, as you've explained, you can deal with that right from the beginning of the study in your study design. If you only discover this problem after the study is done and you're now analyzing and you say, "Ooh, look at this! This is unexpected. We didn't realize that some people just simply couldn't afford this particular drug." Can you now apply what is the appropriate response to that? Can we go back and do matching, only look at those patients who could afford in this group rather than looking at all patients? How do you deal with that situation?
Okay, but I think brilliant as it moves right on forward. I think there's a number of ways, and I think in this case we're looking at doing exactly what you just suggested, and both for the confounding aspects of it and assessing that, you think about looking at comparing different people and thinking about vitamin D, its effects in people, again, with equal resources, doing exactly what you said, kind of a subgroup type of an analysis, and seeing if that's the case. And we'll actually do an example in just a moment to kind of show that. In the area of looking at it as an effect modifier, now you're kind of doing that comparison type of work, almost like you saying, does vitamin D affect older minus vitamin D in people younger and older, and kind of doing that subgroup type of an analysis, just as you suggested. But it's important that that get done rather than that other piece. And I think as we move forward, we're going to see that in, I think, in very, very good details as we move forward and think about age. Beautiful introduction to this area. So our consideration in this case of looking at age as a confounder. And our critical question here is, does treatment with agent A compared to usual care improve mortality? Probably a question that that Dr. Weber asked with his trials, Dr. Welton asked very easily, very, very simple type of question. Let's move it forward. Thinking about treatment A. In this case, we're going to assess confounding and adjusting again for confounding. And this is kind of our little area. So in our treatment group, we have 100 people. 80 of them are young, 20 of them are old. In our control group, we have 100 people. In this case, though, 20 of them are young and 80 of them are old. We're still testing, does this agent work with regards to mortality? So if we look at the total group of 200 people, and we're looking at those that are treated, those that were in our treated group, those that were not treated in our group, and looking at mortality. If we look at it just very, very squarely out in this particular case, we're seeing that the risk of dying in the treatment group is about 12%, 12 over 100. The risk of dying in the control group is 18%, 18 over 100, fairly simple. We then do a relative risk, which is what we would want to do. It's one of our indicators of dying in the treatment group compared to the control. We come up with a relative risk of 0.67, suggesting that there is a little over a 30% reduction in mortality, making us think that the treatment really does make a big difference. So we think that we have something here really good. Following Dr. Weber's cue, maybe we need to look at it a little bit differently, and maybe we need to know what's happening. So maybe we should stratify, in this case, by age to see what we're getting. Well, in this case, we'll take our young patients, we take our old patients, and analyze them in this, stratify them by the different age groups. Now let's see what happens. We knew what we had in the beginning, and we knew what our direction was going to be. So now let's kind of look where we saw basically a 30% plus protection with this with the agent being treated. Let's see what it looks like when we stratify by condition. In our risk group, in our risk group in the young people, 8 over 80, come up with a 10% reduction. Risk in the control group, 2 over 20, we come up with again a 0.1. So really at that point, we're not seeing much of a factor. In our older group, it's a 0.2 risk. We look at 4 over 20. And in our risk group, we look at 0.2 again. Now what do we have? We have basically really no effect whatsoever. We're seeing a relative risk now of 1 in both of these groups, which would say that we have a confounder here. We have a confounding effect, and that this agent is really working no better to protect against mortality than would not. Dr. Weber, Dr. Welton, I think y'all see this quite often. This is maybe almost a common scenario, you would say.
Age is independently associated with the outcome here. The outcome is mortality, and of course we know as you get older, you have a third factor.
Sorry, Professor Walton, could you please speak a little louder? Your voice is very, very soft.
Sure.
Having a hard time hearing you.
Sure.
Thank you.
Yeah, sure. I was just saying that here we have a third factor, age, which is associated independently with the exposure and the outcome. So it's, It's a confounder and we're dealing with it by stratification.
But Paul, could you, we heard that a little bit, but would you be able to turn your volume up just a tad?
Maybe if I put on,
Yes.
I'll move to earphones. You go ahead, Ed.
Okay. Sounds good. So I think we see the effect of the importance of, in this case, of looking at age. Let's do one more. And I ask you, the subject matter here is not the important piece. It's the consideration of age. And so here is a question. Do higher and lower positive in expiratory pressures, PEEP levels, affect clinical outcomes in patients with acute respiratory distress syndrome? And we are going to go to this article that was in the New England Journal of Medicine. We're all reading this together and we're looking at this, and this is an important piece as we think about acute respiratory distress syndrome, as we think about ventilators and offering different pieces. So this is the overall case, but let's read this paper very quickly and be able to kind of consider. So here was this tribe asking what this critical question is. And so if we look at this and we immediately go to, as Dr. Welton said last time, always go to table 1 where they're showing the characteristics. As we would look at something like this, we're starting to kind of see, is there a difference in the 2 study groups with regards to age? Okay, we look very quickly and we're seeing pretty much of a 5-year difference in what people in one group versus another. So I'm kind of alerted to this as we start to think that there might be this difference that we're seeing in age very quickly. Think how quickly we're reading this paper. So right away, we know that respiratory disease is associated with age. And now we're seeing in these 2 groups that we're comparing that maybe we see a difference. So very quickly, so there were 2 ways that we adjust, if you remember, with regards to looking at a confounder, in this case of age. The first scenario that we did when we were looking at the treatments just a minute ago, we stratified, as Dr. Weber said, do that subgroup analysis, break them down. In this particular case, what they've done is put it into a regression analysis, and they've done the analyses and adjusted for age. And look what they see when they do that adjustment for the unadjusted, just the pure out. It would look like you would have in the higher PEEP group, if you will, the mortality seemed to be higher in the higher PEEP group. So you would associate in that case. However, after you adjusted for age in your regression analysis, all of a sudden now the lower PEEP group becomes the group that's most associated with mortality. The point is 2 ways that we do with confounding: the subgroup analyses, where we break it up and look at it, and then the second way is that we look for the adjustment. I hope that we went through this and it looks like we can do this in fairly quick order, hopefully.
And adjusting, just to put it another way, is often called standardization. It's basically standardizing the third factor in the 2 groups. So it's sort of taking that third factor out of the analysis. And as you mentioned, age would be a classic for many chronic diseases because it's most definitely usually independently associated with the outcome. And if you look at that table 1 here, it's clearly associated with the exposure as well. So to be a confounder, the factor has to be associated with the exposure and independently with the outcome, as you mentioned earlier on. It's a very good example.
Good. Thank you, Dr. Welton. Excellent. Let's do another. And we have a number of examples, and what we would hope is you're starting to kind of look and coming to this in fairly short order. And so we do a number of examples in here. So here's another. This is looking at lung cancer and vehicle exhaust in the trucking industry and trucking industry workers. The concern here is exhaust from diesel fuels, and it seemed like there was an increase in lung cancer associated with individuals in the trucking industry. And the thought was that this might be associated with exposure to diesel fuel and diesel fumes, excuse me. And they were looking at different trucking industry workers. And so you see, this would be a situation that you would want to turn around and consider. So you're reading the report, you're maybe participating in the study, whatever this is going to be, and what the issue might be. So now let's think about, perhaps, is there a confounder here in this particular case? A little different now at this case from what we would see with regards to age, the traditional ones. Let's look at some of the other. Let's remember our three pieces. The factor must be associated with the exposure, okay? It must be independently associated with the outcome being investigated, and it must not be in the causal pathway of an outcome. So the question that you have here is, in this case, what about smoking? What about cigarette smoking, that we also know is greatly affected and associated with the outcomes that we see here? And we bring into this case, excuse me, I'll go back if I can. Sorry. Try to go back. Maybe I can't. Okay. Okay. Anyway, let's do another, in this case. So we're brought in smoking with the trucking industry. Now let's look at perhaps another one, looking at oral contraceptives and looking at cervical cancer, and asking the question, do we have a confounder? Do we have a confounder that we can kind of consider? So we're looking oral contraceptives and cervical cancer, but also thinking about the age at first intercourse. This would be one where you're kind of doing your study design, you're starting to look, but also something for you to turn around and consider, do we have a confounder? So the first question is just that, do we have a confounder? If we look at it purely off of the total amount, using oral contraceptives, never using oral contraceptives, and building this forward and looking at our groups right here, we come up with an odds ratio of 1.9, basically almost a twofold greater risk of the use of oral contraceptives and the development of cervical cancer. That's a fairly big risk. So, but we also want to think about our age at first intercourse. So if we were to take the age at first intercourse, less than 20, age at first intercourse, greater than 20, or at this piece, calculate that odds ratio now look what we see. Do we have a confounder? Well, we're now seeing, where we're doing that subgroup analysis, we're saying maybe yes, indeed, that when I calculate my odds ratio for oral contraceptive use and cervical cancer, I come up with an odds ratio of 1 in the younger group and an odds ratio of 1 in the older group, indicating that I do have a confounder. There is a confounding effect in this particular case at looking at age at first intercourse. So let's look at it in this type of condition and think, okay, let's look and truly define, at that case, age at first intercourse as our confounder. The factor must be associated with the exposure being investigated. That's oral contraceptive use and age at first intercourse. Let's look at this kind of quick analyses. Is it associated with it? So we've looked at this as a confounder, the age at first intercourse, not. bringing in here using contraceptives or not, and we find that 20% of those who never used oral contraceptives at intercourse, and now we have 50% of those who used oral contraceptives at age of intercourse. So we're seeing that association. We're seeing the association again of oral contraceptive use and age at first intercourse. The second factor, it must be independently associated with the outcome being investigated. At this point, age at first intercourse and cervical cancer must be independently associated with the outcome being investigated. Well, let's look. And boy, it really is kind of one in here. So now we're looking at age at first intercourse and the development of cervical cancer. What we're seeing here is an odds ratio of 8, meaning that the younger, if you age at first intercourse less than 20, has an odds ratio of 8 times greater risk of developing cervical cancer compared with those individuals that were 20 years and older. I think it really kind of is quite evident. We see this association. We now have another check mark, age at first intercourse and cervical cancer. And then very seriously, it must not be in the causal pathway between exposure and outcomes. In other words, it's not up here. So in order for this to be true, the first to be true, age at first intercourse is kind of is in the pathway of that occurring. So we look at these scenarios. If this were the case, and it were not a confounding, you would see the same identical results from no confounding compared to confounding. But we see when we consider age at first intercourse in that pathway, we see a different pattern. We see a different level. So this would indicate it is not in the pathway. It is separate that we have in here. So at this point, we can say that it looks like we do have an association between a confounding effect of age at first intercourse. The question that you also have, very important, is causation along with the association that we're thinking. It's very important to differentiate between causation and association, as you well know, and each of you is experiencing through. You want to show that many times a study may show a link, an association between an exposure to a substance and a health effect. And this does not necessarily mean a direct causal link, as many know. The association, again, may be kind of indirect, again, knowing what the different variables are, what the different variables are not. And there's also criteria that we've used in the past, the Bradford-Hill criteria that we'll talk about. We've talked a little bit about this class, where you're looking at a causation and factors that are here as opposed to an association. And this is kind of important as we think about things like confounding and looking at that kind of association. And we'll do a few more of these scenarios and exercises. One more here. And we're heading deliberately kind of in the land of looking at blood pressure. I know that many of you know that that's what we focus here. Here's a question. Is there an association of lead and hypertension? And so this particular study is a study examining the results of a cross-sectional study, which evaluated the relationship between lead in blood and hypertension, looking at a sample of 254 males and 271 females in the general population that were not occupationally exposed to lead. Think a fairly straight, standard assessment that I suspect some of you have even actually done something very, very similar. In this case, we're looking at, again, the association of lead and hypertension, looking at this multiple logistic regression, this adjustment analyses that Dr. Welton referred to. It showed that if some well-known factors such as age, sex, overweight, smoking, and alcohol are taken into account, that blood lead levels are well correlated with hypertension. In this case, it's going to say the results would be that the results suggest that even modest lead absorption is able to influence the probability of being hypertensive. You would say that blood lead is an important consideration in the development of high blood pressure. Dr. Welton, Dr. Weber, I know this is this has come up over the years, over the I guess over the decades now, and I think this is pretty much the standard analyses and assessment that did come up and bring in blood lead. Any comments that you might think?
No, I mean, you've shown it here, and of course it applies to the group that's studied. I've forgotten which group is in here, but some people, lead might be important, and we often think those who are around refining of gas, or maybe children who are exposed to paint that
There we go.
contains lead. And many parts of the population might not get this exposure at all. So the relevance of the relationship might vary a lot.
Yeah. And I'm thinking this is kind of the standard way that we know that these are potential confounders that would have come up and that would have perhaps cluttered some of our thoughts. But then these analyses, you're asking the question, is blood lead associated pretty much with hypertension? So you want to adjust for those potential confounders that might be affecting this aspect and moving it into an analysis or an adjustment, as you said. And now we come up with the conclusion again of the of blood lead is indeed an association.
And one other issue, Dan, you may come to it later on. Here it's a relatively small standard sample size by epidemiologic criteria, at least. And we have 1, 2, 3, 4, 5 potential confounders that we're looking at. In fact, it seemed to work well here, but sometimes in a small, relatively small sample size, if you have a lot of variables that you're trying to adjust for, you may have too many, and they may not actually, you may not achieve the goal of dealing with the confounder. And so you have to be careful. Even though you might have done an adjustment, it might not have been sufficient to deal with the confounder. So
perfect. Wonderful.
Yeah, the other thing that comes up too, Dan, is I look at this list of confounding factors, and some of them are very strongly associated with hypertension. Age, for instance, being overweight. Those are two really compelling associations to hypertension. Smoking, alcohol perhaps also are associated with hypertension, but not as strongly as age or overweight. And how do we handle these confounders, some of which are powerful confounders and some of which are more marginal confounders? And does this come back to what Professor Welton was saying, that perhaps we can overdo the number of confounding factors, and we'd learn more if we just perhaps eliminated or dealt with age and overweight and saw if that was adequate to see if we could show a link between lead and hypertension.
Yeah, both of y'all are always spot on, and I think that's the direction that we have in this case, and we will come to this in later conditions. It's so important that if I'm going to identify something as a confounder in my analyses, I have to justify why I'm including that. And I think in particular, and I think exactly what you're saying. If I don't do that, it's what most of us call a fishing expedition. We're just putting everything in the kitchen and hoping something comes out. It's so important in this particular study, I think that they did do this in this cohort that they were looking at. But I think it's so critically important to identify and justify why you're including the different pieces that you have in your regression model. I think
And
a
I think,
critical piece.
sorry, I was going to say, I think certainly in the review process and many times in the paper, in the review process, most of us will always want to see the raw data
Yes.
unfettered, and then we want to see the models as they were developed. And you might have 2 or 3 different models. The first one introducing factors that, as Dr. Weber said, are well known to be associated with blood pressure. So here we have age, we have overweight, we have alcohol. These are all very well known to be associated with blood pressure. And then you might have the next model, model 2, which introduces all 5 of these variables as potential confounders. And many times with big data sets, you'd have a model 3. So I think you will see that in papers, and you'll certainly see it if you're a reviewer, and you may ask them if you don't think they've included some critical variables to go back and do an analysis with them in. And if you think they've put in too many variables that are just cluttering up the analysis, drop some of them out.
Very well stated. Let's go into a little bit more, and I think these are a couple of examples that will kind of moving forward, and I think these are going to be really clear where both Dr. Welton and Dr. Weber to, I think, bring here things that we're very familiar with. So here is a simple study looking at the dialysis modality and 2-year patient survival. And this is a study of the association, again, between the initial dialysis modality and a 2-year patient survival. They have a cohort of 3,512 elderly patients with end-stage renal disease. And they have done this. They showed that after adjustment for the estimated GFR in dialysis initiation and a number of other factors, they found that this unplanned hemodialysis was associated with a 50% risk of death, and another the dialysis associated with a 30% increased risk of death compared with the planned hemodialysis. Dr. Wilson, I know this is right down your alley, so we're thinking, is GFR a confounder here?
Sorry, I was on mute. That's a
No.
good question, Dan.
Yes.
Could be. We could explore that.
Yes. I think this, and I think it's an important piece in here as we look and move this this part through. So here's our thought. Here's our dialysis modality. We're looking at patient survival. They're coming into this, but they're also figuring that GFR is indeed a confounder. There we want to say, is it a confounder? Okay. As we look for the confounding, we feel like, I think here that the analyses were rightfully adjusted for GFR because one, from the literature, we know that that GFR prior to the start of dialysis is a risk factor for survival, what that area is. That's the first piece. The second one, it's known, again, that on average, patients starting renal, excuse me, dialysis tend to have a higher GFR than those starting on hemodialysis. And now you have an association between the dialysis modality and GFR. Finally, if we look at GFR prior to the start of dialysis, it may influence the choice of dialysis modality, but it's certainly not an effect of the dialysis mortality. It doesn't, you don't determine what you're going to do, but it can affect it. as it was measured before initiating the therapy. And then the third requirement, again, for GFR to act as a confounder basically has been fulfilled. So each of the three pieces that we said in this particular case would identify GFR as a confounder here. And therefore, we can kind of conclude that GFR prior to the start of dialysis is indeed a potential confounder that should be adjusted for in the relationship between the dialysis modality and the patient survival. So in this case, the investigators recognized this, identified GFR as a confounder, adjusted for it in their analyses, and still came up with the conclusions that the modality is associated with survival. And I know many of you are not overly, like I am, not overly familiar with dialysis and these pieces, but we should be able to go through this logic and look at this and identify GFR as a confounder in this particular case and appropriately adjust for this case. Dr. Welton and Dr. Weber are both experts in this area, and if I might ask their comment.
Yes,
This
is a difficult topic to really analyze, because there are some factors, and we can discuss whether they're confounding factors or intrinsic to the situation, but in a number of communities, a number of settings, there's an economic factor at play. There may not be adequate hemodialysis resources available, and so peritoneal dialysis may be selected because it may be more simple and more available, rather than the fact that it's perhaps the better or not the better choice for a particular patient. And that is something that comes up a lot. What's happened, unfortunately, is that we get into this interplay sometimes of government policies, availability of therapies, economics, that are hard for us to analyze, because those sorts of data are not necessarily available in a manuscript or a paper or even a fairly broad-based analysis, but they do play a part in this. And I know some of the places where I've worked, the decision for hemodialysis versus peritoneal dialysis isn't just based on eGFR, though that could be a legitimate decision based on the analysis you show, maybe just based on the fact of what is available right now for a patient.
Excellent. Thank you. Let's move to the second case. In this particular case, and again, in this case, we've appropriately considered GFR as a confounder. Let's look at another, again, a kind of a dialysis type of or end-stage renal disease type of approach. Looking at, again, I know this is not everyone's expertise, but we would hope you would be able to come in and look and identify what might be a confounder. In this case, they're looking at a body mass index and the risk of end-stage renal disease, one that we're all interested in. Basically, the larger you are, the greater the risk of end-stage renal disease. Many people have done it. In this case, we're looking at body mass index and the risk of end-stage renal disease using a database of 320,000 people. This now we're getting to those numbers that Dr. Welton says good to look at. In looking at members of this Kaiser Permanente, this is a large cohort of individuals, mostly in the United States. A very good, strong database and a good database network where they have good indicators of good health. The study was able to show that adjusted for a number of confounders like age, sex, and race, but not blood pressure, increased body mass index was strongly associated with increased risk for disease. In this case, we're going to kind of think, should blood pressure had been there, or maybe that it shouldn't have. So we're going to go through and try to identify, should blood pressure have been considered as a confounder with age, sex, and race? Should it have been considered with a confounder? Very similar like GFR was in the previous type of study. So let's go through our criteria. So we think about it. So we review the different properties for potential confounders, as should always be done. And again, because you want to make sure what you're putting in. In this case, it can be stated that blood pressure is indeed a risk factor for the development of end-stage renal disease. Okay, we have that. So there. Further, there is an association between body mass index and blood pressure, in that higher body mass index is also associated with the higher blood pressures. Blood pressure is, though, however, also an effect of body mass index, even if it is and it is even in the causeway of the development of end-stage renal disease. So the larger an increased body mass index would be associated with an increased blood pressure, which of course is associated again with end-stage renal disease. So in this particular case, the body mass index blood pressure does not satisfy all the criteria for a confounder, because it's in that causal pathway. And again, the main analysis should not include blood pressure as a confounder. Dr. Weber, Dr. Welton, your thoughts on that? Do you agree with that
Well, it's
identification?
often a difficult issue to resolve. You know, you ask the question, how much is this on the causal chain? And it clearly is a part of the causal chain. And how much of it might be independently a confounder? So I think when you get to something like this, you would often analyze without blood pressure and do an analysis that assumes blood pressure is a confounder, and see, does it make a big difference? And you certainly stratify to look at blood pressure as a potential for being in the causal chain. But I think this is where it becomes quite difficult in the analysis to try to understand how much should we really exclude it completely as a confounder? Is all of the effect of blood pressure in the causal chain here, or is only part of it in the causal chain?
I think that's exactly on target, Professor Welton, and and I think your suggestion is absolutely the correct one. You have to do the analysis both ways. And of course, this is a question that varies from country to country, region to region, because certainly here in the United States, 2/3, even closer to 3/4 of all people who finish up with end-stage renal disease do so because of diabetes. But also an important group of people finish up with end-stage renal disease because of hypertension and do not have diabetes, or they may have other conditions where hypertension is a major intermediary of the final renal outcome. So I think what you said is absolutely what you would have to do. I think if any one of the three of us were a reviewer of a paper that included hypertension or didn't include hypertension as part of the analysis, we want to make sure that all the bases were covered and we knew with and without hypertension what the outcomes would be.
Great. A good field here. So, and in this case, the authors they certainly put blood pressure in their models and their analyses, but they did not adjust as a confounder. But I think it's very appropriate to do this. So we're going to do some other polling questions and stuff, but kind of in summary, again, confounding can greatly affect your study results. All studies should be assessed for confounding and reported in manuscripts, and the confounders that are there should be, it's important to justify why you're identifying something there. And when we do think about or you're addressing confounding, it's detected, the analyses should either be stratified or adjusted with a clear explanation of what's doing in there. And as we all kind of stated and emphasized, it's important to thoroughly assess that confounding, do the analyses in both ways, or as you're reading a paper, making sure that if there is a potential effect of confounding, it does vary. It's not real easy and it's not always black and white, making sure that that study has addressed the issue of confounding, how they've addressed that issue of confounding, and making sure that you're satisfied that it has been appropriately adjusted so that you're not allowing the confounder to be a distortion of what the points are going to be.
And you did a superb job. Let me just say the obvious, that if the factor is only associated with the outcome, but it's not really associated with the exposure, and you adjust for it, what you're going to get is two equal outcomes. So you can over adjust and get
Yes.
into trouble that way, just as if it's a true confounder and you don't adjust, you'll get misleading results. So you have to be careful, and you can
Yes.
learn from others. There's usually a literature if it's an established area, and that's helpful too, to see what other people have considered to be important confounders.
Dr. Welton, thank you. That's so spot on. And it's at this day and time, is this with writers, etc. It is so important, that piece, that we do that type of assessment and do that due diligence. Each of us do that due diligence
Right.
as we read a paper, make sure that that is the case and we're not being misled
Yeah.
either way
Under-
by a particular paper.
Understanding biology as you construct your models is very, very important, because if you're just a machine and you're using programs and you throw everything in, you might do more harm than you'll do more good. And I think all three of us get a lot of papers where people don't understand biology and they just put in a lot of variables. You look at it and you say, there's so many variables in here, I'm getting dizzy from just trying to read them. And it's because they can do it that they feel compelled to do it. And many times that's not a good, sensible approach.
Excellent. Thank you. Now I'd just like to share, we're very excited everyone is being a part. All of our participants will receive the newsletter for the World Hypertension League. In the newsletter, we are going to add a section specifically for this group and this network, where we take a theme or a small part of it and include a part of in the newsletter, some particular feature, maybe a little small addressing of confounding with some examples of different things that have come through our webinars and part of the program, and kind of feature something that might be hopefully helpful to you as writers of studies, as different pieces that might be helpful. And hopefully the newsletter will include some materials, one that gets you familiar with the World Hypertension League, but also with the different topics that have come out of this focus. Also, the wonderful questions that you've been asking, we ask you to continue to do that. We will continue to respond to that and post these answers, the questions and answers, on the World Hypertension League website. And we will continue to do this all throughout the entire series, throughout the entire program. And we would hope that that might be a resource to you as you consider these different factors, as you write your papers, as you review studies. And we want you just to be a part of our overall group. one piece, a little bit of my commercial, we have a what called children's art program, and that's not to suggest that you will be part of this, but if you do have some children, or you're familiar with children wherever you are, we'd like to emphasize that for World Hypertension Day, we have a children's art program, and this can be any child that has a part of the art. There's a way that you can participate in this. It's coming up, and we'd like to encourage you, any child anywhere, and you be their sponsor to bring their artwork forward. And this piece, and this is described nicely on the website. And we would like to just encourage you to have this for World Hypertension Day, which is May 17th, and maybe submit some artwork for that particular piece. That's my part of the commercial. And then the next piece, as we emphasized last time, our World Hypertension Congress will take place in India, February 21 through 23, 2025. We will have another piece of this program there, where we'll do it actually live in India. In the morning, we'll have morning sessions that will address the issues of writing papers, submitting work, and getting your work published and different types of studies. And we'd like to encourage participation. There'll be the traditional abstract presentations that we'd like to encourage you to participate in, but also we'll tell you more about the morning sessions that we would be having. Dr. Welton, any additional comments that you would like to say about the Congress or about the World Hypertension League?
Well, we're very excited about the Congress. It's the first time we'll be in India, and the next time maybe that we talk, we'll put the registration information up, so anyone who might be interested being there in person could look at it, could look at the registration. And if you're not going in person, there are also options for online or virtual participation.
Great, thank you. Okay, well, with that, we will stop. We have some great poll questions, and we'll stop and look forward to going through the poll questions.
And then I'm going to have to apologize. I have to go to the convention center to give a presentation. So okay. I'm going to say bye to you and Dr. Weber and all of our colleagues at the CDC and all the participants. But thank you for having me.
Very good. Thank
you so much.
Thank you, Professor Wilson. Thank you, professors, as always, for this wonderful, wonderful presentation. Confounding is always a factor to consider during data analysis and interpretation, and we greatly appreciate how clearly you described confounding with examples and suggestions on how to minimize its effects. So thank you. And we apologize, everyone, for the delay in enabling the chat box. We had a few technical glitch, and we thank you for your patience and understanding. And please remember to type the questions in the Q&A chat box. And we would also appreciate if you could fill out the evaluation form that we shared in the chat box. Your feedback is important to us, and we really value your suggestion. Thank you, Eva, for putting this the link in the chat box. All right, so before we open the floor for questions, we would like to share a few poll questions. So Dr. Mukhtar, could you please read the first question for us?
I'm waiting. Oh, good. They're there. Thank you.
Eva.
So the first scenario is about a case looking at association of the risk of sleeping in a bed. And this goes back to the 19th century when they compared the risk of dying while laying in a bed with riding on a train. So a recent investigation found that some bed construction during that time used high arsenic levels, contributing to the risk of actually dying while laying in bed. The finding was submitted for publication, and the question for you is, how would you respond as a reviewer? Number one, would you say publish as presented? Number two, propose a follow-up study regarding the gravitational effects of the prone position. Number three, indicate concerns for potential confounding, as sick and high-risk individuals are often in bed before death. Or number four, use these results and recall and destroy all beds manufactured before 1920. We wait for your responses online, not in the chat box, please. I see a lot of people are writing their response in the chat box.
Are you able to check one of the options? If yes, please write yes in the chat box.
And I see a lot of people writing option C, or the third option.
Thank you. It looks like you are able to check the options, the poll questions. So.
Eva, what are you seeing behind the scenes?
I have about just 50% have answered, so I'm going to give it a few more seconds, if that's okay.
Sure.
Oh, wonderful. A little bit of background on this. This is from Mark Twain, that those that are familiar with the author Mark Twain. And he made a comment that he was more scared of laying in bed than he was on riding on a train. And he made that emphasis. He said that more people die lying in a bed than do riding on a train. And he had some statistics to kind of go forward and show this. And so in this particular case, an investigator took that comment and now today found this type of association that was there just basically an association with laying in bed and then dying. So I was kind of thinking not to put Dr. Weber on the spot, but as an editor, a journal editor in chief, Dr. Weber, you got this paper, and so now you're asking this great group what their thoughts are, and I kind of feel I'm very pleased that the third answer, in my opinion, is probably the best one. But how would you deal with this with reviewers or even this particular study?
Well, I agree with you, Dr. Lackland, that this certainly is a fairly easy question to answer, and I'm delighted that most of our colleagues agree with us that it is option 3, and potential confounding here, because as you point out, and as it points out in the narrative, so many people die, unfortunately, in bed because of they're dealing with a terminal serious illness. And we've seen this in a number of studies, and sometimes this kind of confounding can be very misleading. And if I can just bring up a topic that both you and I are very focused on, and I think most of our colleagues who are with us today are also focused on, is the whole issue of salt, of sodium. And I think most of us believe that people who eat too much sodium chloride, salt, are at risk of high blood pressure and adverse cardiovascular outcomes. But then we sometimes see people who publish a paper, and it does get published in a journal, where they say, well, that may be partly true, but we have evidence that people who eat very, very little salt have an increased mortality rate and the serious outcomes. And that is also true, but misleading, because again, when people are sick and in a terminal condition, they probably stop eating or reduce on how much they eat, and so they consume very little salt. And they don't die because they're consuming very little salt. They die because they have another very serious illness happening. And that again, sometimes we call these things or use terms, Dan, like reverse causality and so forth. But we have to be really careful in drawing connections without really thinking it through and considering all the implications. So if I were editing a journal and someone sent me an article with this conclusion, I'm afraid I may have to reject it.
Yeah, I think it's there. And the other two, just very, very quickly as you look, the first two, one was to basically publish it, and now you've got a paper that says there's an association, as Dr. Weber said, there's an association between laying in bed and dying. Well, that's, in one sense, there was a confounder there, and that might not be, you don't want to publish that because it would be misleading. The other is, my feeling is, there's not enough evidence to suggest another study from this one because it was not properly adjusted. In one sense, it's saying exactly what Dr. Weber is saying. Don't use the paper, do it properly, and draw the proper conclusions. Don't let this go. And this is how some things can go out of hand. So I think that next one is there's a confounder here, and that needed to be adjusted, and that point. I think we can go to our next question, our next poll question. Great responses. Thank you. Thank all of you.
Eva, next question, if you could put the next question.
Okay.
Thank you.
Yeah, we have two more poll questions to go.
Just trying to find my polls. Okay. There we go.
Thank you. So in this case, an investigator compared populations from two regions. A warm southern region where average temperature is around 32 degrees Celsius, with mostly retired population, and a colder northern region where the average temperature is around 21 degrees Celsius. And most people living there are working younger population. The study found a 4 times greater stroke mortality rate in the southern region than in the northern region, and attributed it to the warm temperature. So how would you respond as a reviewer to this finding? Number one, would you say these are great results and should be published as presented? Number two, there are confounding concerns from age, and the author should stratify stroke rates by age categories. Number three, there are confounding concerns from age, and the author should include age in a multiple regression analysis. And number four, both stratification and adjusting would be appropriate. I'll give you 30 seconds to click what you think would be your best response.
Hey, I think this is a very common phenomenon that we see almost in every everywhere, all around the world. And I know it probably yours. There's a place where that's very comfortable for mostly retired people to go. And I know again, put Dr. Weber on the spot here as the EIC. This is a common paper, I think, that at least I see very often, where I have one geographic area compared to another, and it's associated with often some type of factor associated with that geographic location. I think very, very common. I'm so pleased most everyone got it in the general idea. I think you could probably, you need to adjust for the confounding aspects that we have here, particularly from age, and it could be stratification, it could be confounding. But I know, Dr. Weber, I think, how many times have you seen this type of paper coming before you with some identifying some characteristic that may or may not be there, but the fact that they didn't adjust for age, it makes a misinterpretation.
Yes, indeed, it can make for a misinterpretation, and I think most of us, looking at the responses we have here, understand that it's not as simple as looking at the data and seeing more people dying in the southern warmer region and blaming it on the high temperature. But at the same time, we should not necessarily dismiss the possibility that a warm temperature could be associated with certain poor outcomes. After all, warmer temperatures may be associated with various conditions, infections, other things that are typical for warmer climates, though unlikely that these effects would lead to stroke rather than other bad outcomes. So we do see these sorts of what you might call misinterpretations of data. And so certainly you would want to stratify by age, and you'd also, I think, also want to consider other explanations for the findings. And for instance, in the United States, and of course, it's a unique situation here. In the United States, we have some differences in the ethnicity of people who live in the North and the South. And it may be that people of a certain race or ethnicity may be more vulnerable to strokes than others. So, in fact, the data are correct in a sense, and stroke may be an issue in the warmer climate, but now we have another confounding factor, namely ethnicity or race could be an explanation. So sometimes it gets to be very complicated, and that's why we really need to have good reviewers. Speaking as a former editor-in-chief, I depended very heavily on people who had a good understanding of proper statistical approaches to data, so that they would tell me and warn me as the editor, for goodness sake, don't accept this paper until you've told the authors that they have to consider confounding factors, and they should at least acknowledge age, they should acknowledge ethnicity, they should acknowledge any other variable that could be playing a part in these findings. And just to immediately jump on one obvious difference, the difference in temperature, is not adequate. So I think it's been a very good question, Dan, and I'm glad it's come up. And I'm happy that most of our colleagues have understood the need to look beyond the original conclusion.
Okay, good. And I think they're being quality reviewers. And so we thank you. We want you to get in this kind of role to be kind of a reviewer in this particular case. I think we can go to our third question.
Okay, so this scenario looks at the salt intake by gender. An investigator evaluated salt intake using 24-hour urine measurement in 100 men and 100 women between the age of 40 and 50. The study found that men had statistically higher salt intake than women. How would you respond as a reviewer to this finding? Would you say the results are clearly confounded by fast food consumption and should thus be rejected? Or the results are confounded by smoking and should be stratified by smoking status? Or the gender disparity in salt intake seems appropriate and should be further reviewed? Or the fourth response, which is it is inappropriate to report salt intake for men and women as the physiology is the same. Interesting scenario.
Well, it is interesting, and it's again an area that often does cause confusion. We have no information provided about the importance of fast food consumption, which is important. There's no question about it. That and the whole issue of fast food, the fact that it's relatively inexpensive, and for many people.
Dr. Weber, let's get our poll.
Okay.
You're
All right.
He's giving away the answers.
I haven't voted yet, so we can all go ahead.
Those were good comments. Those are excellent comments, but
I'm glad you stopped me in time.
Yeah.
And actually, I need help. I wasn't sure where I'd be voting. So you guys are going to tell me what to do next.
Oh, good.
How are we doing, Eva?
Just a few more seconds. I'll let people.
All right.
They're still going.
And Dr. Weber, thanks for sharing the great example from the salt argument that's often made, that how little or no salt intake, among people who've been told not to eat salt because of their condition. So appreciated that.
Well,
I'll go. My biases. I actually think a couple of pieces that were in here for those that are not quite into the 24-hour urine measurement would be considered to be an appropriate assessment of salt intake. I think there was an equal group of men and an equal group of women, and the age group I think is fairly tight. And I think this finding that that men had a higher intake than women would kind of lean a little bit towards me with thinking that answer number 3 would be that this would be something that you would want, that I think would be good for further review. But I'm now going to go back to our EIC, Dr. Weber, and ask him his thought as he saw this paper.
Yeah, all of these possibilities can be considered, and perhaps should have been part of the analysis. I mean, if we look at fast food consumption, it's not necessarily that it's a confounder. It is actually a contributor. And I would like to know more about differences between men and women in their consumption of fast foods, and that may be give us some important insights. So those people who chose that selection are acknowledging an important issue in this whole conversation. The second possibility, that the results are confounded by smoking, doesn't seem on the face of it quite as strong. an argument, though you could say people who smoke may be people who have a more reckless lifestyle, a more casual approach to health, and people who smoke are also more likely to eat poor diets and so forth. So that's not a bad choice. I think there's something to be said about that. I agree with the Professor Lackland that the gender disparity in salt take does seem appropriate, simply because in general, men are larger than women, and in general, men consume more food than women. And so even if they eat the same kind of food and the same diets, men will have a somewhat greater quantity of food and therefore a somewhat greater quantity of sodium. And then finally, it's inappropriate to report salt intake for men and women. I don't think it's inappropriate. What is difficult, though, is how to get good data that is free from all the various biases that have been raised in the first few possibilities. So as an editor, Dan, I'd again be very dependent on reviewers to bring out these issues and perhaps go back to the authors of such a paper like this and say, we've come up with some very important questions regarding lifestyle, what makes people eat the diets they eat, what are the imperatives that make people behave in certain ways. We need more information before we can publish this paper and come to a meaningful conclusion.
Thank you. And thank all of you. This is great. This is what we would like, and hopefully this has been helpful to you. I know there's a lot of great questions in there. Again, we will address all of your questions, and we will post the answers at the World Hypertension League website. And I think we also distribute those, and we can distribute those answers as well. So thank you, and opportunity, I'll turn it back over to the leaders.
Thank you, Professor Lackland and Professor Weber. We have about 43 questions, but we don't have time. So what we will do is, as Professor, you mentioned, the answers to the questions will be posted on the WHL website. Actually, the answers to all the questions for parts 1 and 2 are already posted there. So please make sure to visit the WHL website and see the answers to your questions. And before we wrap up, just a quick reminder about our next webinar scheduled for April 18th next month. And please note that we will resume the webinar on the 3rd Thursday at the same time. And the focus of the next session will be on epidemiology of normality, risk, and assessment. Please mark your calendar, register, and plan on attending the session next month. And this is really what we have you for today. And we apologize again for the technical glitch we had with the chat box. And please take a few minutes to fill out the evaluation form if you have not done so. And we thank the WHL faculty and everyone who participated in today's session. We really appreciate your time and attention. Please feel free to reach out with any questions about the webinar series. And we look forward to seeing you all next month. Have a wonderful rest of the day. Thank you all, and goodbye.